Yeah, thank you very much for this nice and musical introduction. So we change gears, and I will report a little bit on what I think are global challenges in cancer care, but I use these as examples because I think that what we do in cancer research and cancer care will change and transform medicine. So the talk will be in these 5 topics, and I will give you short examples on these problems. Cancer as a problem of high complexity, which we have actually to manage, and we have to learn in medicine to manage complexity much better. Then examples on precision medicine, a new field in medicine that also requires handling of huge amounts of data, big data. Then a hint to the demographics of cancer, and finally some problems on global disparities that will challenge, I think, our social systems. So let's start with complexity. If you have not read this book already, you should, because it's in a very, very understandable way describing cancer research and the history of cancer as we saw it over the last 2,000 years. And if you just look at this simplified table, you have to be reminded that for the last 2,000 years, we probably didn't even know what cancer was about. So it is, since Galen in the 1st and 2nd century, seen as a disbalance of liquids. It was seen as a disease of black bile that was stocking into the vessels, and basically, if you had a disease that we today call cancer, it was probably only some very simple stocked blood. Now I don't see the screen here anymore. If you just, yeah, thank you. It was only in the 19th century by researchers like Virchow in Germany and an American researcher that we could visualize cells and recognize that in the end, cancer is a disease of cells, a cellular disease. And at that time, surgery was coming as a principal treatment for many of the cancers. Actually, it was overdone over the last 100 years. It's only in the 20th century, 60 years ago, that we recognized that cancer is almost uniformly a disease of genes. And only over the past 10, 20 years that we recognize that these genes are highly complex in regulation, and that we can see cancer as a disease of very complex cellular signaling networks that we now can target with more specific therapies. So basically, a transformation of the knowledge that goes along with a transformation of the treatment, and that has just started. So, as I told you, very complex signaling networks. This is one of the hallmark papers in the field where you can see a cell that is organized in different pathways or circuits. And if you don't understand anything in this, you will certainly believe me that it's very complex. It's looking like basically the trail map of a station here at the station in Cologne, or main station in Frankfurt, where many, many complex pathways are interlinked and inhibited. And this explains you 2 things. You need several factors that cause cancer, because otherwise they're counter-regulated. And also it explains you why we didn't understand it so well for such a long time. It took a long time to understand this complexity. Now, progress came about with the revolution of being able to clone the first human genome. And the first project that you actually might remember, it was given to the German and to the UK and US president. Bill Clinton at the time when the first genome was sequenced was a project of thousands of scientists worldwide that costed at least $500 million and was a project of several years, basically more than 1 decade. Now, as of today, the costs per sequencing are in constant decline, and as of today, you can clone a human genome for $1,000. It's no big deal. The problem comes from now managing this. You can easily sequence your own genome and cancer genome, and we have to use all this knowledge to be creative in inventing better therapies. So a technical revolution, and that, because you're certainly not biologists, I try to explain you how the human genome in cancer is organized. So you look at a picture that in Germany, like in any other part of the world, many of you're very young, don't remember anymore. This is an encyclopedia, so we call it the Brockhaus in German. And basically, that encyclopedia can tell you how the cancer genome is organized. You can compare that with this system that is organized in 46 books, so 2 times 23 chromosomes, that are organized by 1,000 articles per book. So each book has approximately 1,000 articles that are the genes, and each of these articles contains approximately 1,500 letters. These are the bases, so the single basis of the genome, the DNA molecules. Now, of these 40,000 articles or genes in the human genome, if you look and research and do sequencing research, usually it's only a minority that is altered. So the mutations are, in the case of pancreatic cancer, one of the most dismal cancers, 44 with a typo, so a replacement of a single base or letter, 11 missing articles, 8 double articles. So it can be seen as a disease of only a few genes that you need to understand to actually make decisions. And that reduction of the complexity is one of the ways that we are doing research. It means also that most genes in cancer cells are identical to the normal cells. And if you then further simplify that, and that has been done first with Bert Vogelstein, an eminent researcher in the field, you can group it to 12 pathways. So all of a sudden you try to understand, and you are able to understand that specific pathways can cause certain types of cancers that you need to address and that you can eventually inhibit to improve therapies. So the concept of cancer pathogenesis as of today is no longer humoral pathology where the liquids are wrong, or cellular pathology is a genetic, complex, regulated network, thousands of diseases instead of one, each tumor with a specific genetic and epigenetic makeup, and in millions of patients per year, each with a different social, ethnic, economic, educational background and basic health condition. So somehow it's the art of medicine to manage this complexity. Precision medicine has become very, very hot and debated topic. But I think it has started today. And what you see here is the American president that announces an initiative to bring precision medicine into healthcare. So this has actually pumped billions of dollars into the system in America. The lung cancer is one very good example. I show you just data from our own group in Cologne here, just 2 examples. So formerly one disease, now it has been split, and these are all the relevant mutations. So instead of one disease, now it is forming at least 20 different conditions, and for each single one you can have a different treatment. And if you do that, this is a survival curve, and you see that if you can genotype, so genome, and analyze the patients, it is improving the prognosis, which is doubling the survival time. And in some of the subtypes, I show you just one here, which is the green curve for the EGFR receptor mutation. That is particularly good. You can even triple the survival time by giving only a tablet, basically a pill to the patient instead of chemotherapy. So it has improved the survival from 8 months on average in advanced lung cancer to 30 months. Now, big data, to handle all this, it is necessary that we collect all the information, and as very often in the field in the United States, the field is moving fast, and especially in the United States. There is a partnership between the American Society of Clinical Oncology, SAP, and politics. Joe Biden just giving a lecture at the last week's cancer conference, where we systematically see a collection of all informations in one system. So basically now already within 1 year, more than 160,000 patient records collected in this database here with a central knowledge database with research knowledge, researcher data, provider knowledge, and genomic information. So basically you collect everything you can get to understand the complexity and to address it even more. And it's certain that there will be discoveries by using such systems. You know all too well at a conference like this is not the end. We are also collecting constantly, like myself, with the watches that we are now all having, more information. They will, in the future, inform you when to take your pills or when to take your blood pressure. And it's this development of using big data in connection with devices that you all have available that will transform healthcare, in particular in cancer. Now let's come to demographics, to the second last point. And this is just to highlight how relevant this problem is, and I think you're all aware. Cancer is one of the leading causes of mortality in the world. Currently, there is approximately 14 million of new cases in the world, with still a too high toll of mortality. The new number of cases in cancer will probably rise by about 70% in the next 2 decades. 1/3 of these cancers could be prevented because they are caused by 5 of the leading behavioral and dietary risks, such as alcohol and others. So a large number. More than 60% of these cases occur in countries that usually have no full access to healthcare: Africa, Asia, Central and South America. So 70% of the cancer deaths, and the annual cancer cases with all this increase will rise from 14 million to at least 22 million in the next 2 decades. And with the last chapter, I wish to actually make a big point on ethical conflicts. I think it has a lot to do how we will run and organize our social systems and our societies on a global level. Because patients and their parents in the entire world are totally aware that there is this possibility to keep Jim Carter alive at the age of around 90 now with melanoma, with costs estimated to exceed $100,000 per year, while in South America, a potentially curative chemotherapy in a young child with non-Hodgkin's lymphoma is unaffordable. It is this disparity that is increasingly becoming aware in all these countries and creating tension. So I'm giving lectures all over the world and realize sometimes that this can be a big problem because you lecture on things that they can't apply. If you go to Argentina or Brazil, it's sometimes quite shocking. The initial costs for induced drugs based on FDA approval in the United States have increased over the past years, and now the monthly costs for a cancer chemotherapy are around $12,000 per year, per month. And you can see that this is creating problems. Anti-cancer drug sales, and just look at this graph, which will be the second to last, I think, are 61% in the United States, 19% in Europe, while the frequency of cancer is 61% in the rest of the world and 18% in the United States. So this is, I think, quite illustrative of where the problem might lie. This is not only on drugs, but also health workers. This cartoon shows you quite nicely, I think, that the global workforce is concentrated in Europe and the United States, while the biggest need for health workers is in Africa and Southeast Asia. So to summarize, I think you've learned that we are getting increasingly able to understand cancer and to do targeted therapies, a beautiful, wonderful development of research, which I'm enjoying to do research on every day. And on the other hand, there is an increasing disparity in this at the global level that we need to address in order to keep our societies intact. Thank you.
Thank you, Michael. Thank you very much. And thank you that you agreed for a couple of minutes asking you questions about this matter. You've described where the difference lies between the treatment of yesterday and the treatment of now. Could you elaborate a little bit more on the difference of the treatment from today to tomorrow? How will, for the customer, if I mean, this is a strange word in that concept, for the patient, this treatment will change the next years, or in the foreseeable future?
I would say in the next 10, 20 years, we will see more and more oral therapies with less side effects, combinations of drugs that you can combine even in one pill. So many companies are designing tablets that combine several principles in one pill. And you will have a combination of sequencing, basically genome sequencing, or even other analysis of cellular systems in the cancer cell, combined with targeted therapies that are oral and usually less toxic than chemotherapy. So the future is very promising. In some of the diseases, especially the one I'm doing research myself, the disease is transforming completely from a chemotherapy-driven disease yesterday to a disease that we will control with an infusion of antibody plus an oral agent that is basically controlling the disease for a very long time. And this will happen for more and more cancers. It's small incremental steps, so it's not a big jump every time, but small incremental steps every year that will improve the prognosis of many diseases.
So which kind of cancer will be curable most easily in the future, and which one not?
That's a big challenge to really predict these things. I would say chronic lymphocytic leukemia, CML, the chronic leukemias are going to be curable. The hematologic malignancies are making a big progress. Lung cancer will not be curable, but will be a controllable disease for many patients for a long time. So they have a much better prognosis and can go to work or continue living. I would say gastrointestinal tract cancers are making slower progress as of right now. And so there is very subtle differences in many different areas. It's very difficult to make a general prediction. But in 30 years from now, I'm confident that more and more cancers can be controlled, even to the point that they do not shorten lifetime.
While we were working on the book, or while I was interviewing you for the book, and we're not talking about the patient, of course, but you mentioned something that I found really striking. You said to me that science and medicine didn't really adjust to the situation where more and more people actually survive cancer, and the way people are taking care of who survived cancer. Could you could you tell us about this? What you meant?
Well, if you have actually treated the cancer, I think one of the most important things is to take care of the patient and, if I could name it like this, his soul. Yeah, you know, it's still a very big trauma to have cancer for many patients. It's really meaning that they are suffering psychologically and to cope with the diagnosis. And some of them, approximately 1/3, have severe adaptation problems. And so one of the most...
What do you mean by adaptation problems?
So
help us a little.
Fatigue, not able to work despite being healthy or actually physically healthy. Deep adaptation problems in the daily life, even in partnerships. And it's like a acute depression at moments where you have to help to overcome this. And I think this is an equally important element of cancer treatment today.
So basically telling people or making them believe that they are healthy again.
And actually feeling they're doing sports. So we have an entire comprehensive program in Cologne where we have a psycho-oncology, sports, so they're really trained, muscular training. So all these little details help to feel like a normal human being after having had cancer therapies, especially in toxic therapies.
Michael, your last chart was particularly interesting when you lay out the foreseeable problems for societies when it comes to a globalized medical system. Ethically speaking, doesn't or maybe you could describe what you exactly mean when we go into politics, when we go into the future of societies. What, in as much a changed medical system will have a deep impact on politics and the future politics in the Western societies.
Well, you can even talk about Europe if you wish, or go to the American continent. So I was getting more and more aware since I gave lectures at international meetings in less privileged countries, not the poorest one, the middle income countries, you would say, Brazil, but you can go to Portugal, Greece yourself. There's a limitation of the resources, and some drugs are simply not available in some countries. So how could you possibly think about families with children being sick of cancer not wanting to come to Europe or to the United States if they have a child that has cancer and has not the right treatment? So I think if you continue to think about the long-term development, this will create tremendous tensions, because with the more and more expensive treatments or more technical possibilities, almost everybody wants to have access to the system.
So let's express this more precisely. What you want to say is that, or you actually want to say that there is a linkage between a possible future refugee crisis and a global medical system?
I think it's part of it. I mean, but health is, I think, one of the most important goods of our life. And I think it's reflecting one more time, but maybe at one of the most important areas, in one of the most important areas, that these disparities will create migration, of course.
So, since you're an expert in that, and since you're traveling so much to so many places and experience that, what could be done to avoid that?
I think it's a big political deal, and we probably, this is now an even bigger picture, if we don't develop a global ethics to actually take care of these things, how we wish to have our globe run in the future, to make sure that in Argentina, Brazil, South America, in general South Africa, you have access to at least the minimal treatment once you get severely sick. It will not be able to keep the international society intact. And in order to do that, we need to overcome the religious things and all the small things that always separate us and develop a common global philosophy of how we wish to run this and then solve it on the political level. It's a very, very big deal, but I can't see if we don't do that, how you ever wish to overcome the current crisis. So it's going very far. I mean, I'm only a doctor doing medicine in a city of Germany, but I think talking to people that have no access to life-preserving treatments and speaking to them in Argentina is really showing you how far we have come, and we need to solve this. So there is, for instance, the possibility that there is agreements between companies to have negotiations on drug prices, which is already done, by the way, but to do it even more to make everything accessible that is relevant for health.
Last question, and by the way, you're not just a doctor from Cologne, you're a champion in understatement. In my opening remarks, I said that you were thinking about studying theology and then you decided to study medicine. If you were 20 again, would you study theology now when it comes to global ethics and all those kind of things you mentioned, or again medicine?
No, I did the right choice because I think to do something that is changing the world, medicine is more concrete. And if you have to be a theologist, you have to be damn good and extremely smart to change anything. So I may become a politician later, but for now I think doing medicine has proven for me to really do little and small things on a local place to give example for a broader context, and I like that.
Okay, great last word. Thank you very much, Michael Hallek.